Good afternoon, everyone. Thank you for coming and being here with us this afternoon. My name is Olivia, and I'm going to be your MC today. I would like to inform you that we are going to start the event now. So everyone who are still outside, we invite all the guests to please be seated. And yeah, so good afternoon, Excellencies, honorable speakers, distinguished guests. Everyone. First and foremost, we would like to extend a very warm welcome to all of you for joining us today at the PPPR site event on Actualizing a whole of society approach in pandemic prevention, preparedness, and response. This event is brought to you by the Center for Indonesia Strategic Development Initiatives in collaboration with Joplang Institute, Pandemic Action Network, and Global Public Investment Network. It's our honor and pleasure to have all esteemed panels and moderator. Thank you for receiving our invitation, and we are very honored with your presence. Before we proceed to the panel discussion, let us first listen to the keynote speech from Ibu Dia Seminarsi. We invite Ibu Dia to the stage.
Good afternoon, ladies and gentlemen, esteemed panelists, dear friends, distinguished guests. I'm deeply honored to be here today as founder and CEO of the Center for Indonesia Strategic Development Initiatives, or CISDI, to address the vital topic of supporting community-led PPPR through a whole-of-society approach. At this first of the three events that CISDI and our partners are hosting in this momentous week, I would like to share some thoughts, ideas, and course of action that we can collectively make under the pandemic prevention, preparedness, and response narrative. The first is the fundamental component will be on vulnerable communities bearing the brunt of health emergency situations. Let us acknowledge, and please allow me to remind everyone here, that at any time epidemics and pandemics strike, it is the vulnerable communities that bear the biggest brunt of the impact. These communities, marginalized and underserved, face not only the health threats posed by the outbreak, but also the socio-economic consequences that follow. The disparities in healthcare access, economic stability, and social support exacerbate their suffering. The COVID-19 pandemic has provided valuable lessons. One significant challenge that emerged was the insufficient attention given to vulnerable communities, largely due to the absence of policies that provide a clear operational definition of such groups. If we draw Indonesia as an example, at the early phase of response and vaccination rollout, vulnerable population groups are simplified into only a few, and multiple key policy documents have different definitions of vulnerable communities. For example, there were instances where vulnerable communities, including but not limited to elderly, mentally disabled individuals, transgender, and non-binary individuals, people living with HIV/AIDS, indigenous people, migrants, and internally displaced persons who did not receive the vaccination coverage they required in a timely and inclusive manner. This gap is further worsened by the experience of countries in the Global South, in particular African countries, on COVID-19 vaccines, which push more countries to deprioritize vulnerable population. The second component is current governance structure. Who sits at the table? The current national to global governance structure for pandemic prevention, preparedness, and response, while well-intentioned, still falls short of being truly inclusive. All too often, decisions are made in distant corridors of power, detached from the realities on the ground. Local communities, civil society organizations, and grassroots actors are left with less than meaningful participation in shaping the strategies that directly affect their well-being. At the global level, and 3 ways for wider civil society engagement in global health policies decision-making have started to materialize in multiple platforms. However, we do have to acknowledge the fact that Global South countries' participation is still sporadic. Countries with wider networks or more global health exposures have better access to these global health platforms than others. This limited meaningful participation of Global South countries and CSOs has hindered the representation and perspectives of crucial stakeholders in decision-making processes. Failing to facilitate that meaningful participation resulted in missed opportunities to provide targeted support and protection to those most in need during pandemics. Civil society is the backbone of the third component, which is the whole of society approach as a key to justice. The question then, how can we bridge the gaps? The answer lies in one of which, embracing a whole of society approach to governance, one that recognizes the equal roles and rights of multiple stakeholders with a particular focus on civil society organizations and local communities. This approach redefines the way we perceive governance in pandemic prevention, preparedness, and response. It acknowledges that communities have invaluable knowledge and experience, both at frontline perspectives as well as communities' dynamics and historical progress. It empowers not only communities, but also countries and the world to engage meaningfully in decision-making processes, contribute to policy direction and formulation, and engage in the design and implementation of interventions. By embracing this approach, we pave the way for a more equitable and responsive PPPR framework, one that leaves no one behind. Communities become active agents in their own protection, drawing on their strength and resilience to face health crises head-on. In the spirit of collaboration for a strengthened health system, CISD and other CSOs in Indonesia have formed a COVID-19 vaccine coalition that enabled expansion of those who are considered as vulnerable, thereby enabling them to be prioritized. We acknowledge that civil society networks in other countries have initiated similar ideas unique to their country's needs. The lessons learned from the pandemic were then carried towards the advocacy for the policy-making process of the new health law, resulting in a more comprehensive definition of those considered vulnerable in the high-level regulation. These achievements not only reflect CSO's dedication to advancing social justice, but also signifies the importance of a whole-of-society approach to strengthen pandemic prevention, preparedness, and response. Our close observation and active involvement have provided a very clear view on the dynamics of the global health architecture following the COVID-19 pandemic. The Pandemic Fund and the recently launched WHO Civil Society Commission can be presented as a commendable step towards embracing civil society as true partners in global health development. We hope that the significance of this high-level week will strengthen transparency and communications between all development actors. There can be more initiative and there can be more improvements in the current ones. As we move forward to a world in polycrisis, we need to be adaptive, relevant, and inclusive if we truly want to have a comprehensive global PPPR strategy. However, as part of civil society, I would like to reiterate the imperative needs on how CSOs are also accountable to the communities we serve and represent. That same principle of equity, inclusion, and transparency we advocated must be the very principle where we implement our joint efforts to achieve a world where the global strategy of PPPR are implemented. I would like to conclude by underlining the dynamics we are facing in this first day of UNGA High-Level Week, as we anticipate the member states' endorsements on 3 key issues, PPPR, UHC, and TBC. We also acknowledge that a number of countries have lodged a formal objection that may jeopardize the final outcome of those political declarations. Although we would like to see those political declarations out and agreed on by the end of this week, we also would like to have political declarations that were made based on the principles of equity, inclusion, and meaningful engagement of all development actors, within countries and among countries. Together, we have the opportunity to reshape the future of pandemic prevention, preparedness, and response. Let us seize this moment and work collectively to ensure that no community is left behind and no voice goes unheard. I thank you.
Thank you so much, Budia, for the very important messages. Now, as we will begin the discussion, I would like to invite Eloise Todd, Executive Director and Co-founder of Pandemic Action Network, to moderate the event. Please, Eloise, stage is yours.
Thank you so much. Good afternoon, ladies and gentlemen. It's an absolute honour to moderate this event today. As mentioned by Budia, the COVID-19 pandemic revealed deep flaws in our global health systems, both at the national levels and the international levels. And we are also clear that there are big issues in the medical supply chain, and these impacted vulnerable groups the most. And as also mentioned by Budia, this point about the inclusion of civil society and CSOs and community groups is absolutely key if we're going to learn the lessons of COVID and do much better next time. So the HLN this week is a big opportunity for us to focus on the choices ahead, but as we've also heard, this is in jeopardy. But we are a big group of civil society organisations, all of those on the screen and those in the room and those that are part of our broader networks, and we will keep fighting for these important principles of equity. It is absolutely fundamental that equity is at the heart of what we do. Now you hear me. So I'd like to invite our distinguished guests to the stage. So if I can ask you to come up, please, Dr. Krishna Reddy Nalamala, President of Access Health International Asia. Ms. Priya Basu, Executive Head of the Pandemic Fund Secretariat. Let's give them all a round of applause. Dr. Karen Brown, Senior Fellow, Global Economy and Development from the Brookings Institution. Dr. Mercy Mwangangi, Senior Director of Health Systems Strengthening of AMRA Health Africa. And last but definitely not least, Ms. Solange Baptiste, Member of the Steering Committee of the Global Public Investment Network. Please give them all a very warm round of applause. So as a friendly reminder, this is a chat show situation, and you've all got about 6 minutes for your responses. If it's brief, we can have another question, and then we'll have some Q&A from the floor. So, Dr. Reddy, I'm going to start with you. We talk about how global north countries and so-called traditional donor countries influence the prioritization and distribution of pandemic PPR resources. What are the consequences of this for the global south, and what has your experiences of that been?
Yeah, thanks, Eloise. Before I divide into global north and global south, I think let us rephrase it that we are a family and we complement each other. The global north requires the labor of the global south. The global north might require the frugal innovation of the global south. Similarly, the global south needs to define what are the people's health needs and needs to prioritize what exactly the country requires. And then ask whoever is giving, whether it is multilateral banks or the IDA or the philanthropy or the private sector. But the tendency, even from the global south, is that the policies tends to chase the money. That means the priorities get distorted because the policies tends to chase the money. I mean, that is the risk of the global south countries if they don't have the capacity to arrive at what actually is the health needs. I mean, what we are saying, whole of society at the global level, these nations also have to practice at a national level in terms of the whole of society, engaging the triangle of governance, the governments, the non-governments, and the people. If that inputs are not taken by the global south, they may not be able to express in a strong voice exactly what they require. The second element is that the global south also need to respect the global north's needs, because there has to be understanding of each other's needs and alignment with that. If the global north needs a protection that the pandemics don't cross the borders, then the south, which is seeking the help, has the responsibility to honor that commitment. So this is my personal opinion in terms of how the global south and the north should complement each other, rather than looking at that I'm helping, you are taking my help.
So it's a mutual relationship. Great. And just thinking about this whole of society approach, you said that we've worked on it a little bit at the global level, but it's needed at the national level. Do you have experience of where that has been implemented and worked well, or do you think it's yet to be fully developed in terms of your experience?
Yeah, the whole of society approach has been evolving. I mean, in the beginning it was the governments was supposed to be responsible. But as everyone realized, especially with the recent crisis, that we are all interconnected and interdependent, and the government alone is not responsible for the governance. If you look at the triangle of the governance, the governments, the non-governments, and the people, these three angles have their rights, their responsibilities, and their accountabilities. So that means when we say whole of society approach, there has to be engagement of all these actors in the governance. But at the same time, each actor should have what exactly is their role and responsibility. If people are asking for a right, the people also should express what is their people's responsibility to their own health, to fellows' health, and others' health. So at a global level, I mean, thanks to the pandemic, there is an increased engagement. I think we are witnessing increased engagement of the various actors. And also a better coordination. If the philanthropy works in silos, if the government works in silos, if the private sector works in silos, that is where the countries get pulled apart, and there is a real danger of actually diverting from what actually the countries require. So the whole of society approach only works when there is a realization of each one's responsibility. And there is a kind of a coordination of complementarity, because what private sector can do, the public sector cannot do. What public sector can do, private sector cannot do. So that realization of each, the strong points and the weak points, and complementing each other, then only it works, whether it's a global level, national level, subnational level, or even at the local level.
Just one small follow-up to that. Whole of society means all those different functions, but it also means different themes. And how much have we seen sectors beyond health getting involved in pandemic prevention, preparedness, and response?
Yeah, so again, that concept has expanded, that health is not just the domain of Ministry of Health. It is the domain of whole of government, the whole of departments of the government, because they are again related. So health cannot be looked at in isolation. So it is not only the whole of society approach, but whole of the governance approach. That means the leadership, I think, should be elevated to the head of the state rather than just Minister of the Health. Then only the whole of government approach and the whole of society approach will be taking place. In my view, I think these are evolving. I think there is an understanding, acceptance that it is one health approach, it is one government approach, it's one society approach. But the process takes time. I think the process is evolving. There are good signs in the global level, at the national level. There is much more proactive engagement. I think even today, the need for private capital to solve some of the SDG goals, there is a recognition. Otherwise, it was only the sovereign countries contributing to the finances. So there is a change in the thinking and engagement of, I think more and more civil society was engaged. I think even today's meeting, there was youth engagement, there was women engagement, the marginalized society engagement. So there is opening up this concept. It's only that it has to fall into place. Yeah.
Thank you so much. Turning now to Priya Basu, thinking about this concept of North and South and partner countries with different backgrounds, how does the Pandemic Fund balance the different priorities from these different partners to ensure a fair and effective global health governance?
Thank you very much, Edelise, and huge thanks to CHISD and partners, to Budia and partners for organizing this. It's really an honor to join you today. So I think, we've heard about whole of society, I would say really whole of the world. I think there's one thing that the pandemic taught us, it was that no one is safe until everyone is safe, and that a virus that starts somewhere, if it's not contained, the kind of havoc it can create. So this really is, investments in pandemic prevention, preparedness, response really are a global public good that benefit everyone. And the investment needs are huge. We did an estimate a year ago for the G20 where we calculated that about $30 billion per year in additional financing is needed to get the global South prepared for the next pandemic, of which about $10 billion needs to come per year from external financing sources. So against that backdrop, the Pandemic Fund was established as an innovative addition to the International Global Health Financing Toolkit. It is the first multilateral mechanism that's dedicated to investing in pandemic prevention, preparedness, response during peacetime, so to speak, in interpandemic years, so that we don't face another cycle of panic followed by neglect. So this time, the international community was quite determined that we need to make those investments so that the world is better prepared for the next pandemic. And some of the key principles of the Pandemic Fund's governance really are the points, Ibudia, that you made in your keynote, which is equity, inclusion, meaningful engagement by the global North and the global South, by governments and civil society. So a lot of care was given to create a governing board structure where we have equal representation, balanced representation from the global North and the global South, 9 seats for governments that are contributing to the Pandemic Fund, which by the way also includes some governments from the global South, and 9 seats for all of the potential recipients, 144 recipients, low and middle income countries into 9 constituencies, 2 seats for civil society, 1 seat for philanthropy. So the structure is, very inclusive. But that's the governance. Beyond the governance now, in terms of the operations of the Pandemic Fund, and we've just concluded our first round of funding, our first allocation of funding, in record speed, by the way. We were only launched at the G20 meetings in Bali last November, and in July we already allocated our first round of funding. And that is for 19 projects that cover 37 countries. And in those projects, and the demand was unprecedented, by the way. So when we announced our first call for proposals, we had requests from 133 countries for grant financing, 8 times as much as we had to offer at that time. But in selecting the projects that the Pandemic Fund wants to support through its first round of funding, our technical advisory panel, which is sort of our advisory body that evaluates proposals, really took care to see, there were certain kind of key criteria that we wanted to make sure that every project represents. One of those was, how engaged has civil society been in preparing the project, and how engaged will civil society be in delivering the project. And within that also communities, because I think again to use a cliche, but pandemics begin and end in communities. So what is the level of community engagement in both the design and the delivery of the project? Beyond that, and Karen, I'm sure we'll talk about that, but genders and kind of looking at every project from a gender lens to see, are women, engaged? Have they been consulted, in terms of thinking about what, measures need to be taken to prepare? Health financing architecture is really fragmented. So how can you bring actors together to work together to support a country's national action plan for health security?
Thanks so much, Priya. So we've talked about the importance of engaging CSOs and communities. It's also important to have an intersectoral approach to these issues. So Dr. Karen Brown, it's wonderful to have you. Could you talk a little bit about how we can bring intersectionality into PPPR strategies to ensure that the unique needs of women and girls and gender minorities from diverse backgrounds are considered? And maybe a little bit on the practical ways of doing this, because it's something that everybody aspires to, but when it comes to actually integrating it and knowing what to do can leave some of us wondering how to implement properly.
Well, thank you so much, Eloise, and thank you to DIA and the government, and all the partners, not just the government, for inviting me to this. My remarks are shaped from my experience as Global Director for Gender at the World Bank and our experience during the COVID pandemic. And I had witnessed other pandemics, the SARS pandemic, Zika, Ebola. And one of the things that still astonishes me in 2020 and now in 2023 is that the gender lens is still often an afterthought. It's not central to planning. It's not central to understanding prevention, preparedness, and response. And it's incredible because, when the pandemic hit and my colleagues and I at the World Bank started to point out the ways in which COVID impacted men and women, boys and girls differently, many colleagues said to me, this is it's an immediate crisis. We can't pay attention to that. And that makes the response even worse. So it's really incumbent on the front end, as Priya said, during times of relative calm in the midst of emerging pandemic storms, to pave the way. So what are the things that we looked at and were problematic that we need to strengthen? First of all, everybody knows this, so I'm sorry for repeating it to all of you. Some of the impacts were on differential male-female morbidity and mortality that differed way across countries, and sometimes it's higher male mortality. But there were some things that when we collected the data that were constant. Certain services, like reproductive health services that women used, were disrupted. And in fact, we had instances of countries directing reproductive health budgets to pandemic response. But we need to tell the health system that women don't stop having babies in the middle of pandemics. And they still have menstrual cycles. And they still have all kinds of reproductive health problems. So maintaining strong reproductive health access is really critical for women, whether or not we're in a pandemic. And those services, as we all know, are still inadequate. And there's a little bit of literature that, in terms of maternal mortality being higher in some countries as a result of the pandemic. Lack of mental health services. And that's really, really critical in times of crises, particularly for women who are responsibility for caregiving. Stress is really, isolation is really critical, and the burdens of care are absolutely astonishing. One of the things that we pointed out that my colleagues were really surprised when we pointed it out, You know, there's a lack of PPE for female health workers, whether it's particularly those who are the unpaid part of the female workforce. We have a paid female workforce, but in many countries, it's unpaid female workers in communities that are responsible for disseminating messages, getting to households, and they were not served. They were usually the last in line to receive things like PPE. We don't even have the data at that point on differences in physiology and other things in terms of mask sizes and other things. So these are all so basic, and yet they were an afterthought. There's 4 things that have to be part of pandemic prevention and response as part of a whole society approach. I didn't even mention the disruptions and the differential impacts in education, in paid employment, in unpaid care, family care, of not only the sick, but of the high male mortality of women who are responsible for livelihoods, schooling children, attending to other sick family members. Care has to be front and central. During the pandemic, you've all heard about, we have good data on spikes in gender-based violence as a result of lockdowns and intra-household tension. Those things are critical. Access to social protection. There's certain parts of the population, informal women workers, which are really important, are not part of registered cash transfer systems, and social protection. And they're the ones who need cash most during a pandemic. Digital access, because when you talk about information flows and other things, there's a gender-digital divide, and women may not have a phone or access to a computer and the internet. And finally, I think the most important thing, although it's now being remedied, was the lack of sex-disaggregated data. And I still think we need to make investments in sex-disaggregated data to track impacts. And this data is particularly important, as Priya and others were saying, at the community level for surveillance and for monitoring. But we don't have the data at the granularity that is needed, not just by sex, but age, ethnicity, and other things. The 4 things that I'd like to see part of a health response is, first of all, GBV response pathways. They're really critical. That's critical for the health system, but it's critical for many other parts of government. The second is social protection, as I mentioned. Governments need to invest in social protection systems that can kick in. These need to be digital, and they need to be linked to other public services that people can access. The third thing that I think is important, which is woefully lacking, and I'm still shocked by this, is the lack of infrastructure and services for care of children, of the elderly, and of disability. And they are some of the most vulnerable, those recipients. But caregivers themselves need to be supported during pandemics. And finally, the private sector, some of the things that I think are important that they need to step up is different forms of anticipatory and pooled insurance options and insurance mechanisms to make rapid response and commodities and supplies available for places at the subnational level. And one of the things that we have is a gender insurance divide, and many women don't buy important insurance products, although they want them. So we have to think about new forms of pricing and the ways that products can be marketed to women.
Thank you. I'm just going to ask a very quick follow-up question. You talked about the need for sex disaggregated data and other things that I feel that we've been collectively pushing for, but clearly not hard enough for a long, long time. Do you have examples of wins that have been achieved on this agenda recently, and what can we learn from that? Just briefly.
I was really impressed with the way that UN Women and UNDP mobilized with the COVID data response tracker, and if you haven't seen it, you should look at it. It's really fantastic. I think it's slowed down since the pandemic, but they brought together important information. Global Health 50/50 is a really important nonprofit organization headquartered in the UK that was tracking health systems response and trying to collect information on beneficiaries. The World Bank mobilized. We had household surveys, phone surveys. But again, they didn't always collect the necessary sex disaggregated information. They'd ask about people generally, but not about women or men. We did rapid phone surveys of facilities, but we didn't always get questions about the kinds of facilities that women have need to have access to or men need to have access to. So I still think that investment in data is a really high priority and really critical, and has to be part of a dashboard that policymakers can use, dashboards at different levels, as well as open to the public.
Thank you so much. So moving on to Dr. Mercy, thanks so much for being with us today. As well as gender as a critical issue, there's also climate change. How can we better understand the intersection between climate change and pandemic PPR policy? And what should global leaders and advocates be talking about in this domain?
Thank you. Thank you for that question, and thank you for the invitation to be here today. When I was walking here, I just remembered it's 3 more months to Christmas, guys. So it's about 4 years from the year 2020, and it's 3 months to Christmas. And why I was thinking about Christmas was because I had the privilege of serving in the front lines of the COVID-19 pandemic in my country, in Kenya. I served as Deputy Minister of Health, and it's interesting hearing from all of us in terms of what does a whole of society approach mean, and your question on climate change. So when COVID struck, I remember it like it's yesterday, yet it's 4 years ago. When COVID struck, we essentially at the same time had a locust invasion in Kenya, and at the same time we had floods, and at the same time we had drought in Kenya, and at the same time in Nairobi we had cholera. And so it was a very intense time period where we were having to mobilize a whole of society approach and not deal with just one issue, right? And of course, what was in the news and what was imperative was COVID-19 pandemic. But I do remember having to set up teams for the capital city to go and deal with cholera cases and deaths that were occurring in the community, and then running back to the Ministry of Health and sitting in the boardroom to deal with COVID-19 pandemic. So it's absolutely crucial, and I keep reflecting back and asking myself, how do we prepare ourselves for the next pandemic? And what happens then, say, if we have all these deleterious effects of climate change? I think one of the things that everyone has talked about is we do have to have structures and governance mechanisms, and I think it's absolutely critical, and very proud of our country, Kenya. A lot of efforts are being made in climate change and to integrate that into programming, and not just for the health sector. And I think much to Priya's points, one of the things that came out was, can we actually see budgets that relate to what we're talking about, right? And can we actually track what it means to be able to finance the health sector for pandemic preparedness and response, but then be able to draw that line and that triangulation with the Ministry of Agriculture, with the Ministry of Water, with the Gender Ministry, and all the other aligned, sectoral ministries that are very key to this response. I think another very important element was appreciating, and I love that we have the banner here, and I kept on asking myself, whole of society. As I sit right now, I sit in AMREF doing the global health system strengthening work, but I remember distinctly that there are other elements of whole of society who we always forget, the academia, the communities. These are absolutely crucial as we discuss these elements, and one of the key things that we did in Kenya is actually form a data consortium that fed us with information, not just from the public systems, not just from DHIS2, not just from government sources, but from the private sector, from academia, and they all brought it together for us, and that really helped us in the response. As we talk about climate change, we're doing the same thing, a lot of moving pieces, But Kenya just hosted the Africa Climate Summit about 2 weeks ago, and we're putting in place mechanisms to actually ensure that that whole of society approach is adopted. As I conclude, and as we were preparing for this session, we've looked at some interesting pieces of work that have come out, particularly from WHO, on what it means to have a whole of society approach. And some of the implementation research says that while we've always appreciated that health cuts across just that one domain of health, and this has been discussed in Health for All in policies, it's been discussed for so many years, all the way back to Alma Ata. It's been discussed. Perhaps we need to talk about what incentive structures have we put in place for a whole of society approach? What are the accountability mechanisms that we have in place for this? How do we track progress truly for a whole of society approach? And I think most importantly, how do we define what works and what doesn't work while appreciating that it's not a one-suit type of affair? Thank you.
Thank you so much. And a follow-up question on One Health for you, Dr. Mercy. Sorry for staying with you a minute. So this interdependence of human, animal and environmental health, how can we better integrate those approaches so that we have policy asks and systems that actually speak to those needs, and also so we're pushing for things that are win-wins or win-win-wins across these different ecosystems?
Yeah, good question. I think one of the things that I was most embarrassed about by my own self was lack of appreciation of PCR screening in the Ministry of Agriculture, right? So we sit right next to each other in Kenya, and when the pandemic struck and we were all trying to figure out how do we sort of have lab systems that can track this, I remember my colleague from agriculture saying, why don't you come in and use, we have a whole lab here, right? And it's a veterinary lab and it's the same technology. We could set you up very quickly, and we did. And I think, much to your point, even at that time, Kenya did have a One Health policy in place. We did have the document, it was in our shelves. But it took, the pandemic for us to be able to realize we do need to look across the road and look at the other ministry and engage. But then since then, I think one of the key things that has been important and has been a good move is the Ministry of Health has set up an intersectoral committee on One Health, and so that actually has the participation of all the different ministries, but importantly, so it also has the participation of the private sector and communities represented there. And I think that's one small step towards really, meeting the ethos of what it means to practice a One Health approach in health.
Thank you so much. So turning now to Solange, we have been discussing in various corridors and rooms here about this global public investment approach, and you've been working with the Global Public Investment Network to introduce a new paradigm for addressing real-world challenges such as pandemic PPR. Could you please elaborate on what global public investment is and what it could be, and how its principles could address existing problems within global PPR governance in particular, especially some of the topics touched upon by our other speakers today? Thank you.
Thank you very much. So I'm sitting here as a member of the Global Public Investment Network, but also in terms of my day job, part of the International Treatment Preparedness Coalition, or ITPC, based in South Africa. And so I often have a very community perspective on global public investment, which is not always how GPI is seen. GPI is often seen as a development, sort of country level financing innovation to come and solve this huge gap that we have for the need for more public money to get us out of the poly-crisis that we're in. And we're seeing that huge, I don't know now, it depends on who you ask and which citation you use, between $2 to $4 trillion gap for the SDGs. So this, to summarize, I mean, we can spend all day talking about GPI, but it's around these key three principles of all contribute, all benefit, and all decide. And there's no particular order. You could start with decide or benefit or contribute. It's an interesting thing to think about which one comes first. But the idea of linking this to a whole of society approach is taking each one of those, I think, and breaking it down and see who's usually missing, what aspect of it needs to be buffeted. And I think from my perspective, the time between pandemics these days is definitely smaller. And so we need to do better. I don't think our issue is really money, our issue is really governance. We looked at the pandemic preparedness, the financial intermediary fund, and how that was set up. There was a win to get civil society to have 2 seats, but it was a huge fight. We often talk about the global fund as the proof of concept and great exemplar of what GPI looks like in action. But if you are coming from a on the ground, grassroots, everyday person perspective, the benefits of what is supposed to be happening up in the halls of Geneva and New York do not always translate into your lived reality. And so I think it is critical for us to kind of start rethinking what it means for contribution. I really liked your comment about the data, the disaggregated data. And I want to include their community data, because there's a whole idea of, when we think about pandemics, we think of countermeasures. And we come from a WHO very clinical lens of thinking about the countermeasure is certainly clinical or vaccine or some new diagnostic, when in fact, I think the missing and underfunded countermeasure is community-led action. And the community was at the front lines of the COVID response. When the WHO and UNAIDS and other bodies needed to find out what was going on, they asked communities, what are you doing, what's happening? The innovations were coming, I think, as the first speaker said, coming from the global south in a large way. I think I'm talking too much. How much time do I have?
Not at all. I've got more for you. Do you want to carry on?
Yeah, I think the other thing I want to say is this idea of GPI needs to be really taken country by country, context by context, and to see, as you know, within climate and pandemics and social protection and whatever the need is. But the idea that a country and a government represents the people is not always the case. So I'll give you an example of some of the discussions that I find are interesting. You would have these very, everybody's, yes, we like GPI, all contribute, all benefit, all decide, lower income countries, middle income countries, please make seat at the table, no more donor recipient divide, let's all contribute, all benefit, and all decide. When you take that conversation at a national level, governments aren't as willing to let communities at the table. So the all contribute, all decide, and all benefit seems to be convenient at a more macro scale. And when you start breaking that down at a national level, you need to see that now civil society, if you want to get to that whole of society approach, civil society, communities at the front line of these decisions that are either climate, gender, food security, the very basic things, they're left out. So it was interesting to keep talking about that.
Thank you. You've slightly answered my follow-up question, which is about the role of CSOs and communities in building community resilience and what the GPI principles offer. I wonder if you might say a little bit about GPI in relation to communities, thinking about PPR in particular and health emergencies situations, the kind of thinking that you're doing on a sectoral level in GPI.
Yeah, I think that communities are the first ones to be at the disposal, at the consequences of a virus. They have to live reality, and therefore they're able to be more nimble, more innovative, more real-time, more effective with a dollar, to come up with these creative solutions, to be able to then bubble up and see what this means at a policy level. So I think that it is important for us to consider that civil society, and let's not use civil society broadly, right? Because, MSF is civil society. Like, if you're not a government, you're civil society. But I'm talking about communities who are on the front lines of these decisions that we make, who are living through drought and flood and trying to feed their children. And obviously the gender lens comes into play. But then how does that translate? It's almost like GPI has to have a top-down and a bottom-up response in order to see transformative change. Otherwise, we're tweaking a system that is just not working for society, and then you want to know why there's sort of this populist, what do you call it, protest in the street, and toppling of governments, because people are not, they feel like they're not being heard. And I think there are other places where you have heard me say, like, just burn it all down. But that is just a feeling of frustration from civil society when you feel like your voice is not heard and things aren't changing.
Thank you so much. So we're about to transition to our Q&A section. While you were thinking up your questions, I just wanted to ask if any of the panel wanted to respond or comment on, or to your other fellow panelists' comments. Priya? Do you want to pass that one along?
Yeah, maybe I just wanted to make the point that, I kind of really agree with the emphasis that Karen and others brought on data. I mean, I think there's one big lesson. There are many lessons we've learned from COVID-19, but one of the big lessons is kind of the importance of data and sharing of that data. And it's only if data can sort of be networked from community up to subnational to national to global level that we can, sort of be able to design sort of strategies around what to do to prepare the world for the next pandemic. So the pandemic fund is very heavily focused on that, and lessons, lessons from the projects that we deliver. What are we learning? What's working? What's not working? So I just wanted to kind of make that point that our first round of funding was very much a learning round, and we are very strongly focused on monitoring, evaluation, data collection from our projects, but also investing in those areas.
Thank you. Any other comments from?
Say one thing that, can you hear me? One thing that I think is really important based on what you said, I think I was most impressed in places like India. I don't know how many of you know about SEVA, the Self-Employed Women's Association, which really is in communities, deep in communities, and they used a citizen science technique to gather data, and that's really, really important. I think there's a spread of citizen science sorts of movements, and I'm not sure that they're collecting as much as they need to, or the evidence and data that collecting on health can be harnessed as much as I think the possibility is. So I think we need a global movement for citizen science and health data.
So spot on, your dream, okay, this is echoey. Your dream is coming true, because there is citizen science. It's maybe not called citizen science, but it's community-led monitoring that is funded by the UN agency, so UNAIDS, PEPFAR, Global Fund, and so that kind of data, for those who aren't aware, is not community-based. So it's not a researcher coming to say, oh, let's see what's happening in this little community, but it is actually the communities themselves seeing the priority, what are the pain points for our lives, and then getting a systematic way of getting that data to bubble up for policy change, and that is happening across the globe. And if I were to link that to GPI, it now broadens the contributor base, right? And then now if communities are at the table and be able to say, well, this is not a one-off, this is actually a trend in the data, and they're now partnering with academics, and it's robust, legitimate, because the first thing they'll say is community data, so it's not real, but robust, legitimate data, then they're also now part legitimately of the decision making. So it's really, GPI can open up that space.
Thank you. So the floor is open. Anybody have a question? Great. We'll go back to front. So 2 people on the back row, and then 1 on the next row. And then you, sir, in the next round.
Thank you very much. Jimmy Wilford is my name, from Zimbabwe. I just want to find out from the panel member from Kenya, the former government official, Firstly, I want to find out, where do governments fish out their personnel, their human resources? Because it looks like we seem to be thinking the government this, the government that. So in relation with that, you were once in government, a deputy minister for that matter. I want to find out, were you part of CSO, civil society, before joining the government or not? Secondly, if you are to be given a chance to be in government again, what are those things that you might, what kind of decisions are you going to make differently in relation to the whole of society approach in terms of responses? Because I seem to think that, when you're looking at civil society that side, government on that side, what happens if a person moves from civil society